Now let's study about Lambert-Eaton syndrome. So Lambert-Eaton syndrome. So let's watch a video first. Which video would be proper? I guess. Yeah, this would do. So only for these ads, guys.
fraction. And because of this, when you check reflexes normally, you have reflexes present. The causes of Lambert-Eaton myasthenic syndrome can be either paraneoplastic or non-paraneoplastic. The thought is that the immune system mounts a response to voltage gain calcium channels from cancer cells, creating antibodies against the voltage gain calcium channels, which has a predilection to specific types of channels found in neurons. Non-paraneoplastic causes are associated with autoimmune diseases such as Graves' disease and type 1 diabetes mellitus. In Lambert-Eaton myasthenic syndrome, these antibodies are produced bind to the voltage gain calcium channels of terminal bulbs of motor neurons, thereby to bind to the P-Q type voltage gain calcium channels, thus really preventing calcium influx and then subsequently the release of acetylcholine into the synaptic cleft. Because your acetylcholine has a result in normal contraction, you will have absent reflexes. Lambert-Eaton myasthenic syndrome presents with proximal muscle weakness, mainly the lower limbs, absent reflexes, hysis, autonomic disorders including the dry mouth, sluggish pupils, and erectile dysfunction. One of the hallmarks of Lambert-Eaton myasthenic syndrome is post-exercise excitation. This is essentially when one performs repetitive activities or repetitive movements, its ability forces depolarization and the release of acetylcholine into the synaptic cleft. This post-exercise excitation causes temporary improvement, which is the hallmark of Lambert-Eaton myasthenic syndrome. Investigations to warn of suspected Lambert-Eaton syndrome and include nerve conduction studies. Here you will find reduced amplitude with increasing magnitude by repetitive stimulation, so repetitive movement actually gets better. You can also check for voltage gain by calcium channel antibodies and support to evaluate for lesions, so for example, by performing a CT chest. Treatment involves treating the underlying malignancy we found. For all symptoms, it's important to monitor. However, for more severe symptoms, things such as anxiety, potassium channel blockage can be used. Normally, there are potassium efflux toxins causing repolarization. And so inhibiting these channels means you have repolarization, and so more acetylcholine can be released into the synaptic cleft, and then muscle contraction. Other medications that can be used include guanine and tamoxifen, which is the acetylcholinesterase inhibitor. Acetylcholinesterase inhibits diacetylcholine in the synaptic cleft. And one of these enzymes you are receiving, you prolong the effect of acetylcholine, which then binds into light into channels by influx and muscle contraction. Then you want to see how journey cause of Lambert-Eaton myasthenic syndrome, paraneoplastic and non-paraneoplastic.
All right, buddy. Let's now discuss about this. Sorry. Let's also watch a video on myasthenia gravis. Okay. Here's a 5 minutes video. That makes sense.
Myasthenia gravis is a Latin expression that literally means grave muscle weakness, which perfectly describes the weakness that happens when this autoimmune disease affects the skeletal muscles. People with myasthenia gravis might wake up feeling fine, but get progressively weaker as the day goes on. And by the end of the day, they might feel very weak, sometimes even getting weaker with repetitive movements, like chopping vegetables. Myasthenia gravis can affect the extraocular muscles, which control movement of the eye as well as the eyelids. So individuals might have diplopia or double vision, as well as ptosis or drooping eyelids. Myasthenia gravis preferentially affects young women in their 20s and 30s, and older women in their 60s and 70s, but the cause of this odd bipolar distribution of age onset isn't quite clear. To better understand myasthenia gravis, though, let's remove normal muscle contraction at the cellular level. First, you gotta normal has that increase in neurotransmitter acetylcholine that invites to injection. So, it's a muscle contraction. No matter what the myasthenia gravis, though, remember that it's autoimmune disease, because single one is antibodies to type 2 toxicity, which has the same consequence. That's it, so back to the next.
Now let's discuss it's a difference. So there are autoimmune mediated or neuromuscular disorders, myasthenia gravis and Lambert-Eaton's myasthenic syndrome. Antibodies like acetylcholine receptor antibodies are formed. Your body's got pre-synaptic calcium channels are formed. So it's postsynaptic, it's presynaptic, extractor and bulbar muscles are affected first, but proximal muscles are affected first. That is standing while standing from a chair. Deep tunnel reflex is intact. So DTR is intact here, while deep tunnel reflex or reflex needs some ions like calcium ions. So because of its absence or decreased calcium ions, so DTR is decreased. Autonomic dysfunction is very rare, but little Lambert syndrome is more associated with paraneoplastic syndrome. So yeah, it's present. So paraneoplastic syndrome, which activates the autonomic or parasympathetic pathways in the body, resulting in autonomic dysfunction. It is associated with thymoma, it is associated with malignancy, tensor test improves weakness on repetitive stimulation by edrophonium, which increases external cholesterol. It does not change anything in Lambert syndrome. Response to exercise decreases strength, while it increases strength because more influx of sodium channel causes more influx of calcium channel in the presynaptic nerve. So similarly, nerve stimulation studies have decremental response while incremental response here. Okay, the patient with proximal muscle weakness and decrease deep tendon reflex that improved exercise Lambert myasthenic syndrome (LEMS). LEMS is an immune-mediated disorder of the neuromuscular junction characterized by autoantibodies against presynaptic voltage-gated calcium channel, which causes decreased acetylcholine release and muscle weakness. It is associated with small cell lung cancer. Therefore, CT scan of the chest can be done. Likely due to an immune recognition of the voltage gated cancer, likely due to immune recognition. So, immune system recognizes the voltage gated calcium channels in the malignant cells, and they cross react with the you know neuromuscular junction as well. Patient typically develop proximal muscular weakness and manifests in the form of gait alteration or difficulty arising from the chair or climbing stairs. Autonomic symptoms like dry mouth or impotence. So dry mouth means sympathetic nervous system, parasympathetic nervous system is more activity. So dry mouth occurs, impotence occur. Cranial nerve, particularly ptosis and respiratory muscle involvement may occur, but typically manifest later in the disease course. Patients may experience post-exercise facilitation, which muscle strength and DTR improve with exercise repetitive similar movements due to accumulation of calcium within the axon terminal. This effect is also seen in repetitive nerve stimulation studies. Okay, Guillain-Barré syndrome is an acute post-infectious polyneuropathy. So after any infection with some bacteria like Campylobacter jejuni, there is neuropathy. So polyneuropathy occurs with Campylobacter jejuni infections, and this causes GBS and is characterized by rapidly progressive ascending paralysis that does not improve with repetitive movement. So Campylobacter jejuni infection, post-infectious polyneuropathy by Campylobacter. So this is a bacteria which is Campylobacter jejuni bacteria. This infects and causes polyneuropathy later. So this is all GBS, and there is rapidly progressive. So it is very fast ascending paralysis. So there is ascending paralysis, not descending, but ascending paralysis. Also, from first down paralysis occurs, legs are paralyzed, then it goes upwards in an upward fashion. Then ascending fashion that does not improve with repetitive movement. And paraneoplastic syndrome associated with gastric adenocarcinoma include abrupt onset numerous severe keratosis. So lesser trilacine. So lesser trilacine is a paraneoplastic sign. So say gastric adenocarcinoma is a tumor which also can have paraneoplastic manifestations like seborrheic keratosis can occur, which is called lesser trilacine, which I had also studied this in dermatology, and acanthosis nigricans can also be seen. Paraneoplastic syndrome causes of the gastric carcinoma cause lesser trilacine, that is seborrheic keratosis, and acanthosis nigricans. So acanthosis nigricans means fat deposition here in the neck, the back of the neck. All right. So this is seborrheic keratosis and acanthosis nigricans, which is a feature in gastric adenocarcinoma. So this is acanthosis nigricans, the blackening, darkening of the back of the neck. Giant cell arteritis is characterized by headache, visual changes, and jaw claudication. So giant cell arteritis causes headache. So there is headache, visual changes because it involves some optic arteries, and there's optic nerve involvement. Visual changes can occur, and jaw claudication can occur in older adults. It is not associated with LEMS. Medullary thyroid carcinoma cancer may be associated with multiple endocrine neoplasia, men type 2, both A and B variants. So medullary thyroid cancer is may be associated with multiple endocrine neoplasia. So medullary thyroid cancer may be associated with multiple endocrine neoplasia, men type 2, both A and B variants. So both A and B type of medullary thyroid cancer. So there is medullary cancer, medullary thyroid cancer type A and type B, men 2A. So men 2A and B both are associated with men. Okay, medullary is associated with men. So men 2A, multiple endocrine neoplasia type 2A is associated with, so 2A is associated with pheochromocytoma and hyperparathyroidism, and while men 2B is associated with pheochromocytoma and mucosal neuroma. So type 2 is associated with mucosal neuroma, so M and N. So type 2 is type 2B is associated with M and N, means so 2B is associated with M and N, multiple neuroma, sorry, yeah, mucosal neuroma, while 2A is associated with 2A means parathyroid hormone, so parathyroid hyperparathyroidism. Thymic neoplasia are thymic common with myasthenia gravis, another autoimmune neuromuscular condition. Myasthenia gravis are confused with LMS. However, in MZ, myasthenia gravis, facial periapparent bulbar weakness may present before extremity weakness. In addition, the weakness worsens with exercise. DTR remains intact, and autoimmune dysfunction is rare. So autoimmune dysfunction is more common in LMS, and there is more, there is less of, there is more of occurrent bulbar muscle palsy in this case. So yeah, it makes sense. Now myositis ossificans. Okay, myositis ossificans. Pathology. So let's see myositis ossificans pathology. I think this makes sense. Sorry for these ads, guys.
That is characterized by heterotrophic ossification, usually within the large muscles, or formation of a normal bone tissue in a normal muscle. Case for presence of two syndromes. That's the non-hereditary myositis ossificans, typically known as myositis ossificans. And this calcification occurs at the site of the injured muscle, most commonly in the arms or in the quadriceps of the thighs. And the second one is myositis ossificans progressiva, or fibrodysplasia ossificans progressiva. This is an inherited autosomal dominant pattern in which calcification occurs without an injury and in a predictable pattern. Myositis ossificans is essentially a metaplasia of the intramuscular connective tissue, resulting in an extraosseous bone formation that is without inflammation. It has zonal organization in that it has three zones. That is the peripheral or well-organized mature lamellar bone, intermediate posterior region, and the central immature non-ossified cellular organs or fibroblasts. The differential diagnosis for this myositis ossificans will be parosteal osteosarcoma, soft tissue sarcomas, including a malignant fibrous sarcoma, synovial sarcoma. Myositis ossificans usually presents with pain, tenderness, focus swelling, joint muscle reduction in the aftermath of a painful muscle condition, and rarely it is asymptomatic and diagnosed from radiographs that are taken incidental. Most ossifications arise in the thigh or the arm and are predisposed by early return of activity after injury. Other signs of this ossification include intercostal spaces, erector spinae, pectoralis muscles, gluteate, and the chest. When a severe injury within the hematoma is recognized, it is important to screen the extremity to avoid excess activity. If further trauma causes direct injury, ossification may reach a spectacular proportion and resemble an osteosarcoma. As genetics are sometimes noted 1 month after the injury, while the lesser past eventually may not be apparent until 2 months have passed. The treatment is initially conservative, and some patients' calcification will spontaneously be observed and others will have minimal symptoms. Disability is a range which of swelling and gives extreme pain upon the slightest motion of the adjacent joint. The limb should be rested with the knee in extension of the elbow in a 90 degrees of reaction until the local reaction has subsided. After local weeks and tenderness have decreased, gentle antiplatelets may be initiated. Much passive stretching exercise are not indicated, especially time lasts for 1 year after the injury because it may restart the process and connect. Early inflammation may be remarkable in these patients, and molecular gas by density is observed for some tissues at about 2 to 6 weeks from the onset. By the 6th acid rate, when they inflate the bones, dialysis, and like osteogenesis of pain 1 to 2 weeks after injury, even so, and then the death next to walk. Alternatively, the mass may be attached only to the muscle.
It's a very bad way of presenting anything. Let us see. Yeah, histological
Here is soft tissue. I think you can recognize the fact that there is fairly dense fibrous connective tissue here. I think you can also recognize the fact that the fibrous tissue is so out here and that there's more fat. And that was called soft tissue.
This was a very better slide. This is muscle tissue, this is fibroblast proliferation, and malignant, it's a benign metastatic bone formation is occurring here. So there are osteolyte-like cells, osteocyte cells. The patient can likely have myocytic ossificans, which is characterized by formation of lamellar bone and extraskeletal tissues like heterotopic ossification. Myocytic ossificans is typically triggered by severe, example, fracture, muscle contusion, or recurrent trauma. So severe or recurrent trauma that initiates the expression of bone morphogenic proteins. So bone morphogenic proteins are first stimulated because of any trauma, which promote in-migration of spindle stem cells. These cells are differentiated to fibroblasts, which produce collagen and extracellular matrix, and subsequently chondrocytes and osteoblasts, which are responsible for production of osteoid and mineralization. Mycelia ossificans typically present as painful firm mobile mass. So there is a painful mass which is formed because of bony consistency, and mobile. So it's mobile as well because it's a muscle and it's not attached completely to the bone. So then it's most common in the quadriceps and brachialis muscle, but can occasionally occur in other muscles as well. So mostly occurs in the quadriceps muscle, big muscles. Okay, extra typically shows intramuscular calcification with the radiolution zones, XL calcification. So there can be radiolution zones that XL calcification can be present, and intramuscular calcification. So it's highly suggestive of myocytic ossificans. It shows the example of the zonal pattern. So zonal pattern occurs with outer areas of relatively mature bone, benign metaplastic bone tissue, and inner regions of fibroblastic proliferation without mitotic and various variable amounts of collagen and osteoids. Okay, this is calcification of deltoid muscle. Closely packed, small, round, uniform neoplastic cells are typically closely packed, small, round, blue cells are neoplastic cells are typical of Ewing sarcoma, which presents with bone pain and swelling, often accompanied by fever. Although it may occur in young adults, it's more common in children, and it's usually fixed to the bone. So it's more common in children, and Ewing sarcoma is more fixed to the bone, not mobile. Ewing sarcoma, this is the small round blue cells, uniform stemous cells. Okay, mature adipocytes with large atypical hyperchromatic cells are characteristic of liposarcoma. So mature adipocytes with large atypical hyperchromatic cells means liposarcoma. These tumors can develop in the lower extremity muscles, but are rare. Typically occurs at age more than 50. So liposarcoma occurs in old age, and it's painless because they cause compression until they cause compression of surrounding structure. So well differentiated lab. So there are adipocytes, and there are atypical adipocytes as well. So the arrows point out to atypical adipocytes with hyperchromatic nuclei. Pleomorphic, so pleomorphic neoplastic spindle cells and new woven bone indicate osteosarcoma. So pleomorphic neoplastic spindle cells, so spindle cells are present and new woven bone indicate osteosarcoma. Although this occurs in patients aged less than 20 years of age, the tumor usually arises in metaphysis, the distal femur, proximal tibia, and mass is not mobile. In addition, this tumor the patient can have no tumor 2 months ago and X-ray, and it's very unlikely for osteosarcoma to develop. Okay, and progress within 2 months. So osteosarcoma takes time to develop. So it is a skeletal muscle border of osteosarcoma. It looks like this, and this is no osteoid formation. Osteosarcoma has more osteoid formation. There is no new bone formation, etc. A ganglion cyst. So ganglion cyst is an outpouching of synovial structure. That is one capsule tendon cyst. So during capsule tendon cyst filled with clear gelatinous fluid. So there can be clear gelatinous fluid, and is present as painless rubbery nodule, most commonly at the wrist or dorsal foot. The thigh muscle is not a common location. Thigh muscle, if involved, rather will mean more of myocytic ossificans. Okay, osteoporosis. So yeah, the medication for osteoporosis means those medications which increase the amount of calcium in the body, or vitamin D, or estrogen, or or parathyroid hormone, but recombinant. So calcium, vitamin D given as given bisphosphonates. So bisphosphonates are the main medications given in osteoporosis which destroys the osteoclastic resorption. So bisphosphonates attached to hydroxyapatite binding site on bone surface inhibit osteoclast mediated bone resorption. Denosumab is a monoclonal antibody that binds to rank ligand and inhibit the binding to rank. So rank ligand is present on the surface of osteoblast. So osteoblast goes into the so denosumab goes into osteoblast, bind to their rank ligand, and inhibit the activation of osteoclast. Recombinant parathyroid hormone. Although parathyroid hormone generally breaks down bone and increases the level of calcium, the recombinant intermediate injection of teriparatide stimulates the pre-osteoblast into bone-forming osteoblasts and increases the gastric calcium, GI calcium absorption as well, renal tubular calcium absorption as well. Okay, bisphosphonates. So alendronate, resinonate treat osteoblasts by inhibiting osteoblastic mediated bone resorption. They have chemical structure similar to that of pyrophosphate and attached to hydroxyapatite binding site on the bony surface. So in the bony surface, they go and attach to the hydroxyapatite binding site. So hydroxyapatite binding sites. Osteoclasts that resorb the bone take up the bisphosphonates and are unable to adhere to the bony surface due to continued resorption. So osteoclast. So first, bisphosphonates goes and bind to the hydroxyl surface of the hydroxyapatite part of the bone. Then when it is resorbing the bone, then it takes in the bisphosphonates and they're unable to attach to the new bone. So bisphosphonates also decreases osteoclast protein production. So it decreases osteoclast protein production. So H plus is not produced inside the osteoclast, therefore breakdown of the bone cannot be carried out. Induce osteoclast apoptosis and decrease and development and recruitment of osteoclast precursor cells. So precursor cells are also affected. So the net results is so slow the rate of bone loss, and some patients experience a small increase in bone mineral density as well. So sclerostin is glycoprotein induced glycoprotein. So sclerostin. So what is sclerostin? So sclerostin is something a very new topic for me, rather. So let's talk about it. Sclerostin is a glycoprotein which is osteocytes. So osteocytes. So osteocytes produce something a glycoprotein which is called sclerostin that inhibits osteoblast formation. So now osteocytes inhibit osteoblast by a glycoprotein called sclerostin. Monoclonal antibody preparations like romosozumab. So monoclonal antibody preparations like romosozumab that bind sclerostin reverse this effect and facilitate increased osteoblastic activity. So osteocytes produce sclerostin, but a monoclonal antibody that binds to called romosozumab binds to sclerostin and reverse the osteocytic effect, thereby leading to more osteoblastic activity. Denosumab is a monoclonal antibody that triggers the bone receptor by binding to the receptor, so rank ligand and blocking the instant interaction between rank ligand and rank. Rank is present in the osteoclast. So teriparatide is a recombinant formulation of identical the 34 amino acid sequence at the N-terminal protein portion of indigenous parathyroid hormone. So it's a recombinant formulation which is similar to 34 amino acid sequence at of the parathyroid hormone. Similar to PDS, teriparatide stimulates the maturation of pro-osteoblasts into the bone-forming osteoblasts that lead on collagens and eventually mineralize the matrix. Teriparatide also increases gastric intestine calcium and renal options. So yeah, more calcium is present in the body now. Ganglion cyst. So ganglion cyst is mucoid degeneration of periarticular tissue. So it is a mucoid degeneration of periarticular tissues. Herniation of connective tissue from joint. So herniation of connective tissue occurs. So herniation of connective tissue. So from joint capsule, tendon, sheath, bursa. So herniation of connective tissue from joint capsule, tendon, sheath, bursa occur, and it is filled with clear gelatinous fluid. So clear gelatinous fluid fill it. So it is filled with clear gelatinous fluid. Okay. And presentation, wrist is most commonly involved, and dorsal foot, knee is also present. Knee can also present rubbery, round, well circumscribed cystic nodules. So rubbery, round, well circumscribed cystic nodules can be present. Transillumination is positive. It's transillumination positive. So it is transilluminant. Observation can be done. Needle aspiration can be done if recurrent, and surgical excision can also be done. Most resolve spontaneously. So this is the ganglion cyst present in the dorsal surface of the foot. The patient can have the ganglion cyst. So the patient has ganglion cyst, which is an outpouching of the connective tissue arising from the tendon, sheath, joint structures like joint capsule or bursa. So clear emission of the gelatinous fluid accumulates in the sac, giving rise to round, well circumscribed form cyst that transilluminate and penal-like examination. The ganglion cysts are more common in the dorsal and polar wrist, but dorsal foot lesions are also common. Most ganglion cysts resolve instantaneously and do not require treatment. They are just cosmetic concerns and sometimes can cause pain or paresthesia, and can be done needle aspirated. So, but recurrence is very common and may need surgical excision. Bloodstream infection like bacteremia can be a complication of cutaneous abscess. So, which also presents local swelling. Unlike ganglion cyst, abscess is red, painful, and fluctuate. So, an opaque, it is opaque and non-transilluminant. Okay, cutaneous abscess looks like this. Gowry tophi are hard, irregular. So it is present here, but tophi is present, or podagra is present in the base of the first metatarsal. So for our first metatarsal, distal metatarsal. So this is metatarsal. This distal metatarsal, you can have it So yes, gouty trophy, a hard, irregular subcutaneous collections of uric acid crystals found in patients with gout. Because of its solid nature, gouty trophy does not trans-eliminate. Patient gangrenosis causing the compression of dorsal cutaneous nerve sensory. So patients, if there is gangrenosis, then it's present dorsally. So dorsal cutaneous nerve sensory branches of dorsal cutaneous nerve. So dorsal cutaneous nerve, the nerve that runs like this, can be affected by the gangrenosis, which compresses this nerve and can present with paresthesia. So superficial peroneal nerve can lead to paresthesia, especially in the lateral side. However, this branch do not contain motor fiber. Motor fibers are not present, and so the patient is not risk for paralysis. So they do not contain motor fibers, so there is patient is not risk for paralysis. So they do not have any motor fibers, so there is no any risk of paralysis. Now, superficial peroneal nerve causes helps in foot eversion. So it's a branch of common fibular nerve, was divided into superficial and deep peroneal nerve or fibular nerve. Superficial fibular nerve helps in foot eversion. So superficial peroneal nerve runs into the lateral part and runs in the dorsal segment. So dorsal parts, so dorsal segments or dorsal parts of foot is sensory supply is via superficial peroneal nerve. Synovial sarcoma can present as a mass adjacent to a joint in young adults. However, due to its solid nature, synovial sarcoma is solid. It's solid. So sarcoma means any malignancy source. It is already solid. This does not trans-eliminate. Osteosarcoma is the border. Skeletal muscles are here. New bone formation occurs. New osteoformation is there. So let's talk about osteosarcoma. So this was a short video, a short video. Okay, I think this will do.
Osteosarcoma represents one of the most common primary tumors of bone. Even though the bones vary in size and shape, they are all made of the same types of cells, and chief among them are osteoblasts, which build up new bone. And osteosarcomas arise from osteoblasts of different sizes, and these cells produce too much osteoid tissue, which is the unmineralized organic portion of the bone matrix that forms prior to the maturation of bone tissue. This is why osteosarcoma is called a bone-forming tumor. Now this image shows the age distribution of osteosarcoma. Osteosarcoma has bimodal age distribution. 75% of osteosarcomas occur in persons younger than 20 years of age. The smaller second peak occurs in older adults who frequently suffer from conditions known to predispose to osteosarcoma. So what are the causes of osteosarcoma? Approximately 70% of osteosarcomas have acquired genetic abnormalities, such as complex structural and numerical chromosomal aberrations. Molecular studies have shown that these tumors usually have mutations in well-known tumor suppressors and oncogenes. With mutations, proto-oncogenes become oncogenes, and these overstimulate the cell growth. To balance out cell growth, there are other genes called tumor suppressor genes, which promote apoptosis or cell death of mutated cells. So oncogenes or mutated tumor suppressor genes allow cells to keep growing uncontrollably, resulting in tumors.
Okay, spindle cell tumor cells. So spindle cell tumor cells. So tumor cells are so name bone formation occurs, but they're spindle shaped. So spindle cell tumor cells, and which is bone and osteoid. So bone and osteoid mixed spindle cell tumor cells represent osteosarcoma, the most common primary bone tumor in children and young adults. So most cases are in the metaphysics of long bones like proximal tibia, the locus of the growth plate, and the site of greatest bone proliferation. Patients typically present with pain and soft tissue swelling and actually usually reveals a lytic bone lesion. So lytic bone lesion is generally very common. Okay, so lytic bone lesion is common. So lytic bone lesion is common. Osteosarcoma arises from malignant mesenchymal stem cells that regenerates cartilage, bones, or fibrous tissue. Therefore, the diagnosis that is confirmed when the histopathology reveals neoplastic spindle cell-shaped stromal cells admixed with the tumor osteoid and thin trabecula of bone. So, new bone formation occurs, lytic lesion occurs in the metaphysis of the long bone. Lytic lesions and new bone formation appears to rest, and there is bone band strangle is also present. Okay, so this is the malignant osteoblast, which are pleiotropic and heterochromatic. So they are malignant osteoblast. Okay, this is an osteoid and this is the new bone form. So dark part is the new bone forming part. Unlike osteosarcomas, chondrosarcomas and fibrosarcoma do not produce osteoid bones. So chondroid produces cartilage and fibrosarcoma produces maybe fibers or fibrous tissues. Chondrosarcoma cartilage is characterized by neoplastic chondrocytes in a hyaline. So chondrosarcomas mean neoplastic chondrocytes in a hyaline cartilage matrix, usually with small calcifications. Neoplastic chondrocytes in a hyaline cartilage matrix, usually with small calcifications. Hypercellular chondrocytes. So hypercellular chondrocytes. This is the blue matrix. This is a finding of chondrosarcoma. So chondrosarcoma has neoplastic chondrocytes. So there is a hyaline cartilage matrix. So this is the blue matrix, which is the hyaline matrix, and so in the blue matrix there are some cells which is chondrocytes, hypercellular chondrocytes are present. This is chondrosarcoma. So in sarcoma, the second most common primary bone malignancy in young patients often arise in long bones and cause progressive pain, swelling, and lytic bone lesions. However, histopathology reveals seeds of small round cells separated by fibrous septa and patchy of necrosis hemorrhage, no osteobondism. So there's hemorrhage, and there is no bone or osteoid formation, Ewing sarcoma. So small round blue cells can be present. So small round blue cells. So yeah, this is Ewing sarcoma. Adenocarcinoma of the lung often metastasize to the bone. However, histology will reveal neoplastic cells lined with mucin-producing cells. So adenocarcinoma means mucin-producing cells generally metastasize to the bone. However, histology will show neoplastic glands. Okay, so this is adenocarcinoma. So this is mucin. So mucin production has occurred here. Therefore, it might be an adenocarcinoma of the lung. Okay, so osteosteoma is small benign bone forming tumor that typically occurs in adolescent boys. So osteosteoma occurs in adolescent boys. So histopath would show irregular patterns of woven bone lined by a single layer of benign appearing osteoblasts. So there's a single layer of benign appearing osteoblasts. An irregular pattern of woven bone can be seen. The presence of large lytic bone lesion and highly pleomorphic spindle-shaped tumor cells may be diagnostic. Unlike so, when there is lytic bone lesion, which is suggestive of osteosarcoma, and the pleomorphic spindle cells. So spindle cells represent osteosarcoma, and that is it. Looking towards type 1 type 2 muscle fibers. Okay, this video will do maybe.
Hello, welcome to Bite Size Med. This video is on the differences between the types of skeletal muscle fibers. Most textbooks will usually have tabular columns with all the differences listed out. If you're trying to figure that out, maybe I can help. Skeletal muscle fibers can be slow twitch or fast twitch fibers. The slow twitch fibers contract slowly and for longer durations, like muscle force. The fast twitch fibers contract faster and for shorter durations, like the force. Medical hyperkinesia. Skeletal muscle contracts as a is active as a much more fluid. It has been used in 18 years. They are hydrolyzed adenosine triphosphate and adenosine diphosphate. This results in oxidation. This can be hydrolysis if the enzymes are resolved. So there are slow twitch and it uses oxygen. This is by oxidative phosphorylation. These fibers are called the oxidative fibers. The fast twitch fibers that instead use anaerobic metabolism and ATP production without using oxygen are the type 2B fibers. Yes, there's a type 2A as well, but we'll get to that later. And type A fibers produce ATP from anaerobic glycolysis. Oxidative phosphorylation is more efficient. It uses more ATP per second than anaerobic metabolism. So the slow fibers can move along without getting tired. They are resistant to fatigue. Anaerobic glycolysis produces lesser ATP per cycle. It's less efficient, so they are more easily fatigued. The type 2B fibers get energy from stored glycogen, so their glycogen content is higher. In between are the type 2A fibers. These are the fast twitch fibers. The body has oxidative phosphorylation for ATP production, making them less fatigable than the type 2B fibers. But they can switch over to anaerobic glycolysis as well, so we do have lactic while the type 1 fibers have lower glycogen. Obviously, the glycolytic capacity anaerobic glycogen will be the highest in the type 2B fibers and lowest in type 1, while they have a higher oxidative
Okay, that was such an informative video.